Okay, so we're talking about today, pediatric vomiting and abdominal pain. So basically, sort of acute abdomen kind of issues. And we're going to go to key diagnoses, and we're going to explore some home points that tie it all together. I'll tell the take-home messages at the get-go so that you have a framework for thinking about the lecture. This abdominal X-ray, as simple of a test as it may be, is still the most useful first step for Emesis in a cell chain. Is there an obstruction of the bowel? And if there is it going to be an upper or lower obstruction? So we'll talk a little bit more about that detail. And then the thing that I want to get across is never use gastrographin in a neonate. We'll talk about what gastrographin is. It is something that at least at the work, you can grab it off the shelf in the fluoroscopy department, something that if you used it in the wrong way in a neonate, you could theoretically kill them. So that'll be to know. I'll break things down, as I do almost all of my lectures, into different categories. And I break it into infant, sort of 0 to 1 years old, child, kind of 1 to 10 years old, and teenager, kind of 10 to 20. Obviously, there's overlap. It's not perfect. The thing about pediatric radiology is the differential diagnoses are short, and we only need to know the age. You have a pretty good differential without having to put effort. Imaging tests that will confirm what you already suspected. So, think about in these things weren't quite hooked up right. And so genital problems that lead to pain and obstruction. You start to worry about mass. There's other things, of course, but you can start worrying about tumors perhaps causing a vomiting. Teenager, you start thinking about inflammatory bowel disease, or acute inflammatory processes. Again, not to say that these are the only concerns by age, but generally speaking, it's kind of useful to keep this in mind. That are going to be slightly different. All of them you're going to want to start with abdominal X-ray, kind of like I said at the take-home message at the beginning. But then using a lot more fluoroscopy, and should be using a lot more ultrasound. And you start leveraging the CT and the MRI from the teenage age range. So let's about infant problems. I'm going to do 3 different infants, all with Emesis, but all different diagnoses. That had Emesis at 1 hour of life, Emesis at days of life, is having Emesis at 3 weeks of life. And I want you to ask yourself, what next study for each of these cases? And the question is going to be answered based on what age, so it's the diagnosis that you think could be causing a problem, is that supported or refuted by the X-ray, and with in mind what test you want to do. This page has a fluoroscopy study showing the diagnosis, the fluoroscopy study, but this one has an enema, and this got an ultrasound showing the diagnosis. So we're going to go through each of these and explain how you approach this. When growing up in the first hour of life, that implies that something to connect right, that you have some major obstruction, perhaps an esophageal atresia. And as far as esophageal atresia goes, the one that I showed you a picture of was actually the uncommon type, so-called isolated esophageal atresia. You see G2, it's getting stuck in the upper esophagus. And then there's bowel gas. So that there's no connection, there's no distal limb that's connecting to the gas. Variety is to have esophageal atresia with a tracheal esophageal fistula. So we still see there is an NG2 that didn't quite make it all the way down, but we see that there is bowel gas present. So we know that there has to be a connection between the airway and the line for that gas to be there. So something I love about this X-ray is you know esophageal limb has to at least come up to the carina because it always stays midline. It doesn't go off to a main stem bronchus. Up to at least the carina, which is about where the NG tube is dropping. So you can do it that this would be relatively straightforward to close because you know without actually seeing them that both esophageal limbs are almost touching each other, which means you can bring them in position, do a primary closure without there being tension on the anastomosis. The difference of esophageal atresia are shown here. They all have different names that are confusing. They're usually indicated by letters, so I would not have you even bother memorizing that. Simply know that the most common type is you have a distal, you have a proximal segment that doesn't communicate with anything, a distal segment that communicates with the so-called tracheoesophageal fistula. The most common type. It's taught a lot in medical schools and seems to pop up on the boards is an uncommon type, the so-called H type, or you just have a fistula. That's not going to present right away because food won't get obstructed, but you have aspiration and pneumonia issues. And I don't even like this artist illustration, is it usually forms more of an N configuration in the actual forms an oblique channel. At any rate, this one's hard to diagnose. People seem to talk about it a lot, even though the one is shown here. Have the lining pouch and the distal going to a fistula. Okay, bilious is within days of birth. And I did bilious. I didn't tell you that earlier, but that kind of changes the game a little bit. Whenever you hear bilious, you think about volvulus. So we'll talk about what really mean. That's the knee-jerk association, and that's appropriate because volvulus is a surgical emergency. It is a left diagnosis. So it's if people have that knee-jerk instinct. But step back a little. Otherwise, you might confuse yourself. So the thing you have to say is the kid is out. Obstruction clearly distal to the ampulla of bladder. That's what the bile be going stream. But obstruction and upper obstruction, portion. Any obstruction distal to the ampulla can cause bilious emesis. An X-ray showing gas only in the stomach. This obstruction. There's no distal bowel gas. This needs upper GI to figure out if there is malrotation and volvulus. As opposed to, which is the one showed as an unknown, bowel that's dilated, not just the stomach or the duodenum. This that there's some obstruction, maybe dyslipidem, maybe colon, maybe down to the level of the anus. If your obstruction picture and you don't realize that that's what's going on, and if you were to do an upper GI, you would kind of slow transit, and you'd say, well, it looks like there's no malrotation, but it's taking a long time. What happens, maybe we'll check up on them in the morning, and you kind of vote. That being said, lower causes, so long as good decompression with an NG tube, are not going to kill you. So obstruction is poor form, not going to kill a patient. Was an upper GI in that patient showing that the patient and volvulus, that lower obstruction, the one of the unknown, had an enema, Hirschsprung, showing transition where the rectum is small but the sigmoid is large. The transition point can actually occur anywhere between the anus and the most common location, though, is going to be here, the sigmoid junction. So let's get those first take-home issues. What contrast is safe to use for a neonatal upper GI? Very great because it's not absorbed. It's not really toxic. Yes, you don't want it to perforate into your pleural or peritoneal space because it just doesn't do a good job of clearing it out because it's really metal. Gastrin is an ionated contrast agent. It's water soluble, as are all the ionated contrast agents. But the trouble with gastrografin is it's super hypertonic. human osmolarity is about 290 milliosms, and you're dealing with something that's 5-6 times more hypertonic. If you aspirate this stuff, it causes kind of raging chemical pneumonitis, which is really bad. So gastrographin, not great. Well, later where gastrographin does have a role in pediatric radiology, there's really only one spot, but very light. Okay, what is malrotation? I think this causes confusion, especially what is malrotation and what is volvulus? What is the difference between the two? So rotation. Let's talk about first what's normal. Normal is duodenal jejunal junction is in the left upper quadrant, your is in the right lower quadrant, and if you your mesenteric base as long as possible in the roughly rectangular shape that is your abdomen, you would do the hypotenuse. You would do the longest possible line. That rotation, that will have no chance of twisting on itself. Any not that is rotation. So if the duodenal jejunal junction is a little bit too low, if the ileocecal valve is a little too high, anything that isn't normal. So there's definitely ways to be malrotated. There's only one way to be normal. Now, the malrotation that is the worst is when duodenal jejunal junction is right next to your ileocecal valve in the same spot, usually in the right abdomen. The problem is now your mesenteric base it's very small. You have a high risk of volvulus. So volvulus is the complication of malrotation. For your intestines, it's an emergency because you off your blood supply. First your venous, then your arterial. That happens, your bowel dies, and at best you get short gut, which is a terrible life, or you die because of the raging sepsis and hypovolemic shock. So it's appropriate that people are very scared about volvulus. For GI look like it's pooling in the fundus. The patient is lying on their back. Enough of it exited the duodenum, so it's peristalsing across. And it was a C shape such that it crosses midline and then comes back up to about the level of the pylorus duodenal bone. That's considered normal. If you follow it out, you then see that small intestine kind of goes from left upper quadrant to kind of middle left lower quadrant to then right lower quadrant. So that is normal. It turns out you don't have to do a small bowel follow through to know normal rotation is present. You can kind of cheat, which is what we do every day. You can do a normal upper GI, and that's good enough. It turns out that the duodenal jejunal junction is so reliable, you don't really even care what the ileocecal valve looks like. The opposite is not true. In the old days, people just used to do an enema to say, is the ileocecal valve in the right lower quadrant? If it is, great. Turns out that's not reliable at all. You get malrotation if you were to just do the enema. So only do an upper GI, and for the most part, that's all we need to do. So what like in this case, the duodenum just drops down and kind of goes off to the right. It never really crosses midline. It never really comes back up to the left of the spine. So this is malrotation. So volvulus. Volvulus is going to be a combination where you give the clinician malrotation, then you bilious emesis. Those two pieces of information together make volvulus. Here on the eye, that is true. Findings called beaking and corkscrew, which we see here, which are signs of volvulus, but I consider that to be icing on the cake. Wait to see this quick appearance to call volvulus, because let's not see this, but you do see malrotation. Well, if patient and they're having bilious emesis, you may be catching the volvulus in the moment, but clearly there's intermittent volvulus, and that still needs to go to the surgery. Your upper GI is indeterminate. Sometimes you're not sure, is this starting or did it go here first, or I'm not really sure what's going on. Some options as a radiologist that you can tease things out. can do an enema. I told you it's not great. It's not terrible, but it's helpful. If it's an emergency, you can just give some more barium and watch to see how the small bowel follow-through plays out. You can also ultrasound to look at the SMA or MV relationship. So we do a 9-hour delay, and we see that the cecum is not where it should be. So this patient does have malrotation. We're kind of wondering if this was right or not. Let's follow through and saw, okay, so this is malrotated. That being said, not the worst kind of malrotation like I talked about, where they're both tucked into the right abdomen. So the risk of volvulus in this patient is higher than a normal patient, but not the worst. What is SMA? So normally, the vein just below the level of the splenic venous confluence should be anterior and rightward of the SMA, which you can identify because it's pulsing. It'll have an arterial waveform. It'll usually have echogenic fat around it. Where that relationship is not true. So that is normal. Now in the SMV relationship sense, the thing that isn't this. Okay. Sigmoid ratio. So from mouth to anus, and in the case of Hirschsprung's, the innervation didn't quite make it all the way to the anus. So you have a non-functional segment of rectum. Because poor peristalsis, everything gets backed up upstream to such degrees that you can have bilious emesis. The ratio is kind of a silly thing because all it is, the rectum is smaller than the sigmoid, and you're mathematically saying that it's a 1 ratio. Kind of silly. Small, sigmoid is big. This transition point can occur anywhere. Normal rectum is bigger because it's sort of the holding spot before voiding. Okay, we'll notice you may have heard about functional immaturity of the left colon. So functionality of the left colon, it's kind of like Hirschsprung lights. Innervation got there, but the nerves didn't quite wake up. And we'll see, first transition point can be anywhere. Here's an example where it's in the sigmoid colon. But in the functional immaturity of the left colon, the transition point is at the splenic flexure. But you cannot call this diagnosis unless it's here. Bizarre. I don't know why it's always here. I have a great explanation for that, but it is. It's always here. The colon is small. Other names for this syndrome, small colon syndrome, and the worstly misnamed is the meconium plug syndrome. Terrible because that implies that the meconium is at fault. Makes confusion with another diagnosis, meconium ileus, which this is not. Functional colon, if you're not sure, you say, hey, what if this is Hirschsprung that's just happening here? You always just get a follow-up X-ray to make sure that everything empties. If it's Hirschsprung's, that contrast you put in, it'll just hang out. But if it's immaturity, by next day, it should all evacuated. What contrast is safe for a neonatal enema? Histochondria, it has a very nice osmolarity, 400, very close to human serum, which is 290. It's water soluble. You could use barium. You could totally use barium. It just gets kind of messy. It's heavier. It's a little denser in usually preparation, which means it's harder to see overlapping loops as well. Histochondria is just kind of very good for G's and enemas. It has some drawbacks in that it is ionic, so you cannot give it for intrathecal use. You can kill someone if you give histochondria intrathecal, so don't do that. Again, hyperosmolarity. Were you to give that to a neonate, particularly a preterm neonate, those guys are tiny, you will intravascularly deplete their volume by sucking it all into the colon with this hypertonic solution. So then you would cause a preload collapse and heart failure. So do not use gastrografin. Once again, we have the exception to the rule. We will get to that later in the lecture. Non-bilious at 3 weeks. Okay, my finding was the classic caterpillar sign, a dilated stomach that is trying to peristalse on itself, this kind of lumpy look. And will be done, and it will diagnose what you probably guessed, pylorosis, also known as hypertrophic pyloric stenosis. A pylorus, the black muscular portion, is thin and floppy in pyloric stenosis. It is thick and taut. There are numbers out there surgeons usually like. Honestly, if it looks abnormal, it's going to be abnormal. If it looks normal, there's no point in measuring. That being said, the surgeons will often ask for the numbers, your single wall thickness, some 3, some people like 4, measure the length, which is kind of silly because the time you can measure a length, it's obvious that there's hypertrophy. Because here, like, I don't know, do I measure from here to here? Do I include up to here? Do I go out to here? If it's normal at length, there's nothing really to measure. Memorizing these numbers, there's a mnemonic, easy as pi, as in pi, 3.14 or 3 and 14. Next. General infant cases before we move on to children. This is duodenal atresia with the classic double bubble sign. Duodenal atresia is not a surgical emergency. However, how do you for sure that this isn't instead malrotation and volvulus? Well, if you're upper GI, one thing you need to do is you need to wait at least 15 minutes to make sure that that barium really doesn't go anywhere. We've had cases where you say, oh, it looks like double bubble, looks like duodenal atresia, and you patiently wait on fluoro, and you'll see a little trickle contrast that goes down into the right abdomen and say, oh, wait a minute, this is duodenal atresia, this is malrotation, it's obstruction, they go to surgery right away. So some surgeons won't even allow you to make this diagnosis until you've excluded malrotation. Kind of on the surgeon and where they trained, and their attendings got burned by having this diagnosis missolved when it was really malrotation. Spit up. Often get radiology requests that say, hey, this patient has spit up, please rule out gastroesophageal reflux. And then I scratch my head and say, what are you talking about? All this reflux is when the spit up becomes pathologic. So how often is it? Someone makes 60 times a day, which doesn't seem like a lot, although kids do spit up a lot. Aspirating, so you see a bronchogram here, that's not good. Have obstruction that's causing them to spit up, but they're really, you should call it emesis, I guess, at that point. With esophagitis, whether the kid's sick or not. Have spit up and they're otherwise a healthy, happy kid, then they're fine. But not gaining weight, if they seem fussy, then you have to worry about it, and then you probably have to pursue it with an upper GI. On to children. So we moved out of congenital problems and on to children. The abdominal pain and emesis. I said earlier, abdominal X-ray is a great starting point. There is clearly a small bowel obstruction here, and we used the mnemonic that was put forward by Lane Donnelly, which is AIM, A-A-I-I-M-M. Each of those letters standing for a different diagnosis in kids that can cause small bowel obstruction. So it's nice. I like it. And to remember all the different things that can lead to a small bowel obstruction. We're going to discuss a few of these in the next slide. This patient here with this X-ray, what happened? CT with appendicolith, you can appendicitis that leads to small bowel obstruction, and I assume that what that is the inflammation causing poor peristalsis in of the distal ileum, which leads to the upstream obstruction. It doesn't always happen. Usually you just get appendicitis without obstruction. But if you have to always respect appendicitis. It's very common, and this is one potential complication. Here's a patient. See, just like the previous patient, in that there's small bowel obstruction, there's free fluid, and an interesting finding. The transition point peaks. It does this weird tapering thing, like really sharp transition point. I said, I don't know what's going on, but there's a sharp transition point. It's obstructed. It doesn't look like a closed loop, but this looks something surgical is going on. Is there an internal hernia? Not really sure. This patient did not have appendicitis. So certainly what this was found to be was a hernia through the bowel, through the mesoappendix. Here's the appendix. Appendix is the triangular fatty attachment element and the intestines were internally herniating through that hole. There's no way we would have guessed that. All we say on CT was, look, there's some tapering. There could be a hernia internally. There's definitely obstruction. We just don't know the cause. This patient had never had surgery, so lesions were unlikely.